Dementia care leadership, research, compassion, and evidence-based best practice. Dementia care is not defined only by clinical knowledge, organizational policies, or professional qualifications. It is defined by how people are treated during moments of confusion, vulnerability, and dependence. Effective dementia care leadership, therefore, requires a careful balance of scientific evidence, ethical responsibility, compassion, and respect for human dignity. A strong leader does not see dementia merely as a collection of symptoms. The person behind the diagnosis remains an individual with a life story, relationships, preferences, abilities, and the right to participate in decisions affecting their care. Leadership begins when this understanding becomes part of everyday practice rather than remaining an aspiration written in a policy document. Understanding dementia as a human and global challenge. Dementia is a general term describing several conditions that affect memory, thinking, communication, behavior, and the ability to perform everyday activities. Alzheimer's disease is the most common form, but dementia may also result from vascular disease, Lewy body disease, frontotemporal degeneration, and other neurological conditions. The impact reaches far beyond the individual. Families may face emotional distress, physical exhaustion, financial pressure, and difficult decisions about future care. Care professionals may also experience heavy workloads, moral distress, and emotional fatigue. The World Health Organization recognizes dementia as a major public health concern with physical, psychological, social, and economic consequences. It also warns that limited understanding continues to contribute to stigma, delayed diagnosis, and barriers to appropriate support. Leadership must therefore address the complete experience of dementia. This includes the person's clinical condition, emotional well-being, family circumstances, living environment, cultural identity, and opportunities for continued social participation. The meaning of leadership in dementia care. Leadership in dementia care is not restricted to people holding senior positions. It can be demonstrated by every professional, carer, or family member who protects dignity, improves communication, and challenges practices that do not serve the person's best interests. Formal leaders, however, have an additional responsibility. They influence organizational culture, staff development, resource allocation, care standards, and the way decisions are made. Their behavior communicates what the organization genuinely values. Compassionate leadership means listening carefully, remaining visible, and creating an environment in which staff members feel psychologically safe to raise concerns. It also means responding to mistakes as opportunities for learning while maintaining accountability for unsafe or disrespectful practice. A leader who expects compassionate care must model compassion consistently. Staff cannot be expected to deliver calm, individualized support if they work within a culture characterized by fear, blame, poor communication, or unrealistic demands. Person-centered care as the foundation. Person-centered care places the individual rather than the disease at the heart of every decision. According to the Alzheimer's Society, care should reflect the person's history, personality, interests, preferences, and remaining abilities. This approach requires professionals to learn who the person is, their preferred name, previous occupation, family relationships, cultural traditions, daily routines, favorite music, and personal sources of comfort can all influence the quality of care they receive. When someone repeatedly asks to go home, for example, the statement may communicate fear, insecurity, or a longing for familiarity rather than a literal request for transport. Simply correcting the person may increase distress. A more compassionate response explores the emotion behind the words and offers reassurance, meaningful conversation, or a familiar activity. The National Institute for Health and Care Excellence recommends care and support that are personalized and responsive to individual needs. It also emphasizes involving people living with dementia and their carers in decisions whenever possible. Person-centered care should never be treated as an optional kindness. It is an essential component of safe, ethical, and effective dementia practice. Evidence-based practice and professional judgment. Evidence-based practice combines high-quality research, professional expertise, and the values and preferences of the individual. Research provides important guidance, but it does not replace thoughtful human judgment. An intervention that is successful for one person may be inappropriate for another. Effective care, therefore, depends on continuous assessment, observation, and adaptation. Leaders must encourage teams to ask whether an intervention is improving comfort, independence, safety, and quality of life. Evidence-based dementia care may include cognitive stimulation, appropriate physical activity, support for maintaining everyday skills, environmental adaptation, pain assessment, medication review, and meaningful social engagement. The effectiveness of each approach depends on the person's health, abilities, preferences, and stage of dementia. Behavioral changes should not automatically be viewed as problems that must be controlled. Agitation, withdrawal, resistance, or repeated calling out may indicate pain, fear, loneliness, overstimulation, hunger, infection, or difficulty communicating. Before considering restrictive or pharmacological responses, the team should investigate possible causes and use personalized non-drug approaches whenever these are safe and appropriate. Medication decisions must always be made by suitably qualified professionals following individual clinical assessment. Communication that protects dignity. Dementia may affect a person's ability to understand complex information, find the correct words, or remember recent conversations. However, communication remains possible and meaningful. Professionals should approach calmly, introduce themselves, use clear language, and allow sufficient time for a response. Asking one question at a time can reduce confusion. Facial expression, body language, touch, tone of voice, and the surrounding environment may become as important as spoken words. Correcting every inaccurate statement is rarely helpful. Communication should prioritize emotional connection, reassurance, and dignity. The goal is not to win an argument, but to understand what the person may be trying to express. Leaders must ensure that staff members have adequate time and training to communicate in this way. Rushed care can unintentionally silence people who need longer to process information. Partnership with families and carers. Families often possess valuable knowledge that cannot be found in clinical records. They may understand the person's routines, preferences, communication style, sources of anxiety, and early signs of discomfort. Treating relatives as partners can improve continuity and reduce avoidable distress. However, partnership also means recognizing that carers may be exhausted, grieving, or uncertain about what to do next. Leaders should promote communication that is honest, respectful, and sensitive. Families need understandable information about the condition, available services, changing care needs, and future planning. They may also require emotional support, education, and periods of respite. The views of relatives are important, but the rights and wishes of the person living with dementia must remain central. Good leadership helps teams navigate disagreements ethically while respecting confidentiality, consent, and legal safeguards. Supporting and developing the workforce. The quality of dementia care depends heavily on the knowledge, confidence, and well-being of the workforce. A single training session is not enough to create lasting improvement. Education should be continuous, practical, and connected to real situations. Staff need opportunities to reflect on communication, distress, pain recognition, cultural sensitivity, safeguarding, ethical decision-making, and collaboration with families. Leaders should also recognize the emotional demands placed on those providing care. Repeated exposure to deterioration, loss, and family distress may contribute to burnout and compassion fatigue. Regular supervision, peer support, manageable workloads, and reflective practice can protect staff well-being and strengthen professional resilience. Supporting employees is not separate from improving care. When staff members feel respected and equipped to perform their roles, they are better able to provide patient, thoughtful, and compassionate support. Creating dementia-inclusive environments. The physical environment can either support independence or increase confusion. Excessive noise, poor lighting, complicated signs, and unfamiliar layouts may contribute to distress. A dementia-inclusive environment should be calm, recognizable, and easy to navigate. Clear signs, good contrast, appropriate lighting, visible toilets, safe walking areas, and familiar objects can help people orient themselves. Environmental design must also balance safety with autonomy. Removing every possible risk can produce an unnecessarily restrictive environment. Good leadership seeks proportionate solutions that protect the individual without automatically removing freedom, choice, and meaningful activity. Research, prevention, and the life course perspective. Dementia research extends beyond treatment and care. It also examines the factors that may influence risk throughout life. The 2024 report of the Lancet Standing Commission identified 14 potentially modifiable risk factors and estimated that addressing them could prevent or delay a substantial proportion of dementia cases. These factors include limited education, hearing loss, hypertension, high LDL cholesterol, smoking, obesity, depression, physical inactivity, diabetes, excessive alcohol consumption, traumatic brain injury, air pollution, social isolation, and untreated visual loss. These findings must be communicated responsibly. Risk reduction does not mean that every case can be prevented, and a diagnosis should never be interpreted as personal failure. Genetics, aging, health inequalities, and circumstances beyond individual control also influence risk. Leadership in prevention, therefore, requires more than advising people to change their lifestyles. It requires accessible healthcare, inclusive communities, education, environmental protection, and policies that give people realistic opportunities to protect their brain health. Measuring what truly matters. Organizations frequently measure incidence, medication use, and task completion. These indicators are important, but they do not provide a complete picture of quality. Meaningful evaluation should also consider whether people feel safe, involved, and respected. Leaders should examine the preservation of independence, participation in meaningful activity, avoidable distress, family experience, staff well-being, and continuity of care. Personal stories should complement numerical data. A dashboard may show that a task was completed, but it cannot always reveal whether the person felt frightened, ignored, or reassured during the experience. Quality improvement becomes stronger when evidence, observation, and lived experience are considered together. Ethical leadership and human rights. Dementia can raise complex questions concerning consent, decision-making capacity, confidentiality, safeguarding, and future care. A diagnosis does not automatically remove a person's ability to make decisions. Capacity may vary according to the decision, the circumstances, and the support provided. Information should therefore be presented in an accessible way, and individuals should be given every reasonable opportunity to express their preferences. Ethical leadership also requires vigilance against ageism and discrimination. People living with dementia must not be excluded from treatment, conversation, or community life simply because communicating with them requires additional time. Human rights are not diminished by cognitive impairment. Respect, privacy, autonomy, and participation remain essential throughout the dementia journey. From policy to everyday practice, a policy becomes meaningful only when it influences everyday behavior. Leaders must translate broad principles into clear expectations, practical training, appropriate staffing, and consistent supervision. Improvement begins by listening to the people closest to the experience, individuals living with dementia, their families, and the professionals supporting them. Their insights can reveal gaps that formal audits may overlook. Sustainable change also requires leaders to remain curious. Evidence evolves, and organizations must be prepared to review practices that have become familiar but are no longer supported by research or lived experience. Conclusion. The strongest dementia care combines research with compassion, professional knowledge with humility, and organizational leadership with genuine human connection. Evidence provides direction, but compassion determines how that evidence is experienced. Leadership connects the two by creating cultures in which dignity, safety, inclusion, and individual identity guide every decision. A person living with dementia remains a person of value, history, and possibility. The central responsibility of dementia care leadership is to ensure that this truth is reflected not only in policy, but in every conversation, environment, and act of care. Reflection question. How can leaders ensure that person-centered dementia care becomes a consistent daily practice rather than simply an organizational principle? From my perspective, leaders can ensure that person-centered dementia care becomes a consistent daily practice by making dignity, compassion, and respect part of every decision and interaction. I believe leaders must set a clear example, listen to the experiences of people living with dementia, and involve their families and carers as valued partners. They must also provide staff with continuous training, practical guidance, emotional support, and sufficient time to understand each person's individual history, preferences, and needs. Policies alone cannot create compassionate care. Leaders must observe practice, welcome feedback, and address any gaps between organizational values and people's actual experiences. By combining research, professional accountability, and genuine human understanding, leaders can create a culture in which person-centered care is not simply discussed, but consistently demonstrated through everyday actions. This article is intended for educational and informational purposes and does not replace individual medical assessment, diagnosis, or professional healthcare advice. 2026 Mary Lourdes Bonnici MBA. All rights reserved. Thank you for your support, and I hope you enjoy this lesson. Mary Lourdes Bonnici.